Hey everyone, welcome back to my channel. So in this video I'll be doing an OBGYN question that's very common. So let's get started. Here we have a 20-year-old woman, gravida 2 para 1, which means she's currently pregnant at 42 weeks gestation. She's like post-term. Is admitted to the hospital in labor. She reports severe abdominal pain. She has received no prenatal care, no history of serious illness, and no medications. This is a red flag, by the way, the fact she has received no prenatal care. Leopold maneuvers indicate a fetus at term. Here, according to a PV exam, her cervix is 10 centimeter dilated, 100% EFIS, meaning that she's fully dilated and ready for vaginal delivery at the moment. The vertex is at +2, relatively near the introitus. After pushing for 3 hours, low forceps assisted delivery is performed because of non-reassuring fetal heart tones. That again, guys, is considered an issue. The fact that we needed instrumental vaginal delivery and that she's pushing in the second stage of labor for 3 hours, this is a prolonged second stage of labor. It should not take more than an hour in a multiparous woman. But in a primigravida, we can allow up to 2 hours. 3 hours is too much for either. Severe variable decelerations and maternal exhaustion are all indications for this expedited low forceps assisted delivery, meaning that the baby had umbilical cord compression, all these stuff. And then we ended up with a 4,200 gram newborn, which is relatively big. He's macrosomic, complicated by shoulder dystocia that requires 8 minutes to reduce. This is another indication, guys, of fetal macrosomia. This woman is probably a diabetic. She's probably had diabetes in pregnancy, whether gestational or not, and she's received no prenatal care. So we weren't able to do any planned C-section to avoid this happening. On examination, the newborn does not move the right arm. So let's see the effects of this difficult labor. What happened to the baby is this whole picture. What happened is a pronated forearm, an adducted arm, and an internally rotated shoulder. This is exactly what went on. As you can see, this is typical of Erb's palsy. That is the appearance of shoulder dystocia. The baby's shoulders are stuck under the maternal symphysis pubis, and because of repeated traction over the baby's neck, we have injured the roots of the brachial plexus, particularly C5 and C6, which are the most proximal roots here at the neck, because those are the ones that give rise to the nerves. I'm just gonna mention right now the musculocutaneous nerve, which innervates the biceps and brachialis muscles, responsible for flexion and supination of the arm. And that's why the baby's arms were actually extended. He cannot move it, means they were extended. He cannot flex it. That's number one. Number two, the axillary nerve that innervates the deltoids is also affected, and we know that the deltoids are the abductors, and that's why the baby's arms, as mentioned here, is adducted. And finally, because these roots also give rise to the suprascapular nerve, that's why he's unable to abduct, that's again, and also to the teres minor. The teres minor muscle, guys, and subscapularis innervate or are responsible for external rotation. The subscapularis innervated by the lower subscapular nerve. So two of the external rotators are now paralyzed, and as a result, the baby's arms, as you can see here, or his shoulder, is internally rotated. So that's because the C5 and 6 innervate the deltoids, the supraspinatus responsible for abduction, by the axillary and suprascapular nerves. His hands are extended because of the biceps and brachialis being innervated by the musculocutaneous nerve, which is also receives roots from C5 and C6, and as I mentioned, internally rotated and adducted. I hope this video helped, guys. Let me know what you think.